Hi, I'm Nick Buescher, Executive Director of the Cancer Program at Penn Medicine, Lancaster. Really excited to be here today. Thank you for inviting me. I am one of those MBA type of administrators, so disclaimer, you're gonna not see any sort of heartwarming stories, and if words like budget or headcount are cause you to experience anger or anxiety, you've been suitably warned. There we go. So today's theme is how navigation is great and something that we all intrinsically value, but how do we pay for that? So getting right into the controversial topic. And the challenge is that nobody's paying for that. When we have the opportunity during certain patient education visits to actually bill out a technical fee for that, we see that patients tend not to show up for those visits. They're really trying to minimize over the entire course of episode what's their out-of-pocket cost. And with insurance companies putting more of that liability onto the patient, people are making tough decisions. It's not always what we might want to choose, so we try not to bill them for things that they don't need to pay for. And that's too bad that we have to justify the value of navigation, but because people aren't paying for that, we have to. There's a lot of people that are competing for the same resources, and so what I try to coach our managers on when we need those resources is what's not the symptom that navigation is trying to address, but what's the deeper problem that's already costing us money anyway? What's that intrinsic problem that's sapping money out of the system? It could be readmissions. And if a navigator can prevent 2 readmissions a month, you've probably paid for that entire salary. And that's what we'd like to focus on. Before we get too much further along, I just want to acknowledge Dr. Randall Oyer, the medical director of our program, and he's here today, and Dr. Beth Hornkamp, who's back home in Lancaster. And they're a part of our implementation team for the oncology care model. We really couldn't do any of this without them. They help me to make sure that none of my ideas are clinically inappropriate. Thanks for laughing along. It helps make me a little bit more comfortable and enjoyable for everybody here. So with OCM, we've got money on the table, really, and we're jumping into this because now we've got some skin in the game on how we're providing cancer care. And although we haven't yet proven the value of navigation, we know that that's helpful, and we're trying to really investigate what are the costs of some of these deeper problems that navigation is trying to address. How we've organized our navigation and our cancer program is into disease teams. We've got 9 clinical teams that folks are organized into, and the navigators have got a couple of different opportunities to elevate and escalate problems that we see. The fastest and easiest sometimes is the daily huddle that takes place within each clinic. That's a great place to escalate really simple issues that an individual patient might be experiencing. If it's something broader and multidisciplinary, it might be hard to touch base with all of the daily huddles in each of the clinics, and so the weekly tumor board might be a good place to escalate that. If it's something much broader that's affecting multiple patients, then we've got a disease team that meets monthly, takes a step back from the clinical process, and that's the group where we're working on developing clinical pathways, identifying what are appropriate drugs for us to have on our breast cancer formulary in this example, or how are we going to work on readmissions for this type of cancer. Before we worked on OCM, this is a rough count of how many new patients we were seeing each year and the approximate percentage of those patients that were navigated. With a requirement now to make sure patients are navigated, we started paying attention to a couple of these areas where the total patients navigated wasn't quite what we would want to see. The challenge with OCM is that we've got to start proving that we're actually navigating patients, and we'll get to that in just a minute. In terms of relative overall size, we're a medium-sized community hospital cancer program, and I think that we've got a fairly rich complement of clinical support staff. You can see the number of staff that we had in place before OCM, and with some of these additional requirements upon us and the value that we placed on having this support services team, we knew we were going to rely on them to help us address some of the issues that OCM is trying to tackle. So what is the oncology care model? Basically, it's a large experiment on a national scale to see if any of the 190 practices that are participating can come up with a way to improve cancer care in 3 important dimensions: quality of care outcomes, the patient experience, and the overall cost of care. And at the end of the 5-year program, hopefully there's some helpful findings that we can release back to the rest of the cancer community on what's going to be an effective way to accomplish this. As far as the requirements for participation, if you're one of the 190 groups, there's 6 important requirements. The one that we're here today to talk about, obviously, is providing the core functions of patient navigation. And as others have said today, like Nine with the Commission on Cancer, you're not required to have a navigator, but you are required to meet these functions of navigation: coordinating appointments, maintaining communication with patients, ensuring that medical records are making it to visits. And we try to do that both incoming and outgoing if we need to refer to a quaternary care center, language translation, follow-up clinical trials, and arranging partnerships with our local agencies like the American Cancer Society. There's also a couple quality measures that I think are related to navigation. I went out on a limb when I was making these slides, but we've already heard a lot today about how some of these issues are actually directly related to navigation. So it's really affirming to see a lot of people are on the same page with us. One of the challenges that we experience is pulling data out of our EMR to supply some of these measures to Medicare. Anything that comes from claims data, Medicare can collect directly. Otherwise, we need to supply that. And then lastly, there's a new CAHPS survey that's been developed for oncology, which asks a lot of really insightful questions. I counted up approximately what category they fell into. And it's not a satisfaction survey. There's only one question on satisfaction. It's an experience survey on how did you experience and how did the care team interact with you. You can see there's a lot of questions about symptom management, shared decision-making, and did we do a good job of listening? So a lot of navigator-specific questions, I think, in how we're interacting with patients. Challenges, we've heard a lot about cost and physician engagement, and I think that OCM doesn't solve those, but it does try to address those. There is the ability to bill a new coordination of care fee if you're in the pilot. It pays about $160 a month for patients that are on active treatment. And you don't necessarily have to use that for navigation. I'm sure that there's some hospitals that are keeping that money for other programs, but we were fortunate enough to be able to spend that on increasing our support services team, as you saw at the beginning of the presentation. And there are requirements and incentives for the medical staff in the project to work with navigators. It doesn't mean it's going to be effective. That's still something around the 4R roles, responsibilities, and relationships that you have to work on yourself. But having addressed those 2 big things, we found that there were a couple of other important challenges that now come to the surface, since those big things are somewhat addressed, at least for us. Other people have mentioned a couple of these, but now that we've got skin in the game and every dollar counts, you really need to ask, is what we're doing going to be helpful? Is it providing a lasting benefit? Or is this a problem that's going to resolve itself on its own? Is the patient going to remember this intervention when it comes time for that survey? And I really like the baton analogy with the relay race. I think to make that analogy a little bit more appropriate, it's not just one baton that's being passed off. Every runner in that race has got hundreds of batons that are currently going around the track at any given point in time. And the challenging part is the navigator needs to figure out which of those batons is most likely to drop, and if dropped, is going to break. And that's really difficult. And you can kind of get a sense now of why that's maybe a little bit overwhelming, and why even though you have a navigator, the baton still can drop. So are we doing a good job of prioritizing patients then? And one of my passions is to make sure that we're actually finding the patients who are going to be experiencing problems or at risk of that, and not just relying on them to self-identify. So how do we meet the requirements? In most of these cases, we were able to assign existing staff to do that. One of the reasons we chose to participate in the model is we felt we were already doing about 1/3 of the work required in those requirements. Another 1/3 we had planned on doing anyway. And the final 1/3, this was a good impetus to push us in the right direction and to give us a couple of resources to make that happen. One area where it wasn't necessarily staffing was around coordinating appointments with providers. We did add some extra navigators to that, along with schedulers, to make sure that we're coordinating everything. But we also spent some time working in those disease teams that the navigators are a part of to make sure that we're also establishing standards for what we expect. How long should it be taking for the patient to move through the diagnostic imaging process in the breast center? How long should it take from the moment that pathology comes back until the first course of treatment is initiated? Unless we know what those standards are, we really can't hold anybody accountable for moving too slowly or perhaps too quickly in some cases through the process. And the navigators fill a role of reporting back to that disease team if this process is working or not for patients as a whole. And that helps us identify and prioritize what the issues are, because we've got too many things to do, and unless we have a real objective data-based approach to figuring out what we're going to do and how we commit these teams to work, it's going to be overwhelming. So in terms of identifying how to navigate, we're trying to distinguish between being firefighters, which everybody in healthcare is really good at, to now being a little bit more of a smoke detector and trying to identify in advance who's most likely to need these services. What I don't like is seeing the patient identify something at checkout and then they get referred to the appropriate support service. I want to make sure that we're using a distress screening tool to help identify those issues in advance, and we're not relying on a referral or a patient self-identifying, but we're trying to find everybody, even if the patient doesn't necessarily recognize that they have that issue yet. I'm not going to go into any detail on this, but it's in the slide. This is more aspirational for us. We haven't quite implemented it fully yet, but in terms of trying to develop a predictive risk tool and help us prioritize who we need to focus on first if there's simply too many patients to see or too much work to do, we're trying to prioritize that based on what's the diagnosis, does the patient have any comorbidities, do they have any behavioral issues going on, and what's psychosocially happening. And so we try to rank and prioritize that a little bit. This is a little bit difficult for us to implement immediately and get buy-in from all of the teams involved, but I think it's a good framework for at least starting the conversation on how do we make sense of too much work and how do we prioritize that. So we're trying to think about where does navigation need to go in the face of some of these requirements and the fact that we're really at risk somewhat for some of this, and it's prioritizing some of those tasks. It's identifying those patients, and it's integrating better with the departments that the patient is coming into and going out of. And it's starting to provide some clear standards for what's being navigated. Do we have standards for how the patient progresses through the health system and what the timelines are? How to address common barriers for patients, as basic as symptom management. Have we identified what that is, and have we standardized training for nurses? And what's the best way to really educate the patient prior to treatment? Is that something that we've protocolized? One of the first nurse navigators I worked with described herself as crack filler because she found problems that were in the healthcare system. And that was a source of endless jokes. It was hilarious. But the issues that she identified were patient barriers, where she was going to be a great component to that. And then she would escalate to the physician practice when there were provider barriers that were occurring in different practices, into the health system when there were things that affected all practices and all patients. So what we are starting to focus on with OCM is how do we reduce the need for navigation to begin with by trying to address some of those health system issues. And this is our overall work plan for the oncology care model. And there's a couple in red that I've highlighted that I think really start to get at some of those overall health system barriers for patients in navigation that contribute to the need for navigators in the first place. So the first item, and this comes out of our playbook where we're starting to release this information to other practices. The first item is the Institute of Medicine Care Plan. And we file this under shared decision making and trying to do a good job of educating the patient on what's happening inside of their treatment plan. Do they understand that fully? Do they understand that they have a choice to make in this and what the side effects and consequences are going to be of that treatment plan? We've turned this into an EPIC template to make sure that there's a standardized way that we're discussing this. Some of the information, to make it easy for the physician, auto-populates from the electronic medical record. Other items, though, you're selecting from a pull-down list. And we want to make very sure, for example, when it comes to prognosis, that we've only got about 4 choices there. And we want to make sure that nobody's dancing around some of the difficult questions and that we're being very direct, clear. And we've run these choices past our lay audience to make sure that this is understandable to patients. Furthermore, this is printed out at the end of the visit, and it's also copied to everybody else that's on the care team, including other referring specialists in primary care. The feedback we've got from this, I think, really supports the concept that this is a help for navigation. Our primary care physicians have said, for the first time, I'm really understanding what's happening in cancer land. And I think that that's going to be a huge help for the navigators and to eliminate some of the issues that they get called in on. Advanced care planning is something that we've heard of today, or heard about today, so I'm not going to go into a lot of detail on this, other than we have sent about 20 of our staff to the Gunderson Lutheran Choices model and trained them on how to help facilitate advanced care planning sessions. That is one of the quality measures with the oncology care model. And symptom management is something that we began working on even before the oncology care model, where we wanted to make sure that we were standardizing the training we're giving to patients on how to best manage their symptoms at home. And that started by standardizing the training that we're giving to nurses on how to best manage that education process and those symptoms. And that's been very helpful. What we saw is at peak about a 20% reduction in emergency department visits. With other priorities related to OCM, that's backslid a little bit, but not too tremendously. And now we're looking at how do we start looking at new types of symptoms that we're dealing with, such related to immunotherapy. This is an example of our daily huddle. The person taking the photo is one of our navigators. But we come together daily for about 10-15 minutes and really run through what's the list of people that are on our worry list that we need to focus on, that have got issues going on. And I mentioned earlier that data is an issue for us. And what we try to do is pull information out of the electronic medical record and spit that back to the care team in a way that will help them understand, here's what's going on that you need to pay attention to. So we've got a report that goes out weekly to the care team that will list all of the patients that are currently on the oncology care model. Are they in an active episode? Are they currently on treatment? And these are some of the quality measures we're tracking. And you just get a simple red-green, have you met the standard yet or not? So instead of doing a retrospective quality review out of our cancer registry on care that took place 9 months ago, that physicians will say, that's not me, that's the specialty as a whole, or that used to be me, but I've gotten better, or that data's wrong, we're now giving them a view of here's what happened last week, and not here's what your quality score was last week, but if you want to get a perfect quality score next month, these are the tasks you need to do at the appointment that's coming up next. And so that daily huddle becomes an opportunity for us to work with our entire support services team and the support team in clinic for the physician to figure out who's going to be talking to the patient today about advanced care planning, who's going to be talking to the patient about how to manage this symptom that's going on based on the phone call that's come in last week. And then we also publish some scores on how are you doing compared to the rest of clinic. The physician's going to be in blue, the rest of the clinic is the bar in orange, so there's a little bit of competition that goes into place there. The red dot is our goal, and we've since added another dot for who's the absolute best person in clinic and how do you compare to them. Kind of the interesting thing about the huddle and the new emphasis that this has put on rapid process improvement is our nurses self-identified that one issue we were having that contributed to extra cost and poor coordination of care was patients were almost self-referring themselves for hydration, top themselves off, feel better for the weekend coming up. And they thought, if there was a way for us to better manage that at home, patients wouldn't need to come in. Our infusion center is a little full. It'll free up chairs and make it easy for us to really fit the patients in that need to be seen in the infusion center. So they're using the daily huddle process. They studied the literature, looked at a number of different recipes for improving electrolytes at home, tested all the recipes, brought that in, and you don't need data from the electronic medical record. These are all pen and paper tallies of was this something that tasted good or not? Do we think that this is going to be popular with patients? So rapid process improvement without needing to rely on anything from IT. And completely staff-led, we were able to implement this idea in a matter of days. So we're running low on time, but how has OCM impacted outcomes? Does any of this mean anything? This is actually information from Medicare on what they're spending at our cancer program each month for patients that are on treatment. You can see here that we as the blue line are significantly above the rest of the country in terms of risk-adjusted spending where we're at. After OCM started, you see a huge decrease, which we're pretty happy about. This doesn't include anything that our disease teams have done around clinical pathways or making changes to our formulary. That work didn't really begin until about here. All of this is really the team working better together through the daily huddle process to coordinate communication. And I think a lot of that is our support services team, and not necessarily nurse navigators, but the process of navigating the patient better as a whole. In terms of key quality measures, this is internally reported data on how we're doing. All of these measures started out at 0% between 1 and 3 years ago. It was things that we weren't doing, but once we converted to a nursing model in clinic where we had nurses supporting physicians, you can see that we're doing significantly better. Patient satisfaction, we placed in the 90th percentile in the new CAHPS survey that came out. And just quickly to get to a summary, I think what was important for us is clearly some early support from IT. We've got a fairly flexible and adaptable medical record system, Epic, that we appreciate, but having that wouldn't have meant anything without having a couple of analysts there to help us adapt the system to how the physicians needed to practice, and the team as well. Having focused time and attention on this, including dedicated time that we could pay frontline staff and physicians to help us, we felt was very important. And just a couple of recommendations that should really just cement what we've heard previously today. We need to be able to demonstrate outcomes in a way that will prove return on investment. And as an administrator, I know that it's not really going to influence me what happened in maybe Chicago or North Carolina. But if we can package that up in a way as professional societies that we can give back to frontline managers, here's an example of a problem that you should study at your local institution. We were able to reduce readmissions here. Maybe you should look at that at your hospital, because that could be, a potential indicator of how much value you could recapture. And then those frontline managers also need some real structure and standards on what's the best way, and are there guidelines on how to implement navigator programs to best guarantee the possibility of some kind of return. Right now, we just know that we should have navigators. There are standards on how those navigators should work with patients, but I think it could be a lot more specific to be most helpful. And then lastly, of course, focus on the barriers that continue to create problems for all patients. Thank you.